Hello and welcome everyone to a very special edition of the Lipid Insights podcast. We're coming to you live from the NLA Fall 2025 Clinical Lipid Update in beautiful Scottsdale, Arizona. I'm your host, Dr. Peter Jones, and I couldn't be more excited about being here surrounded by some of the brightest and most passionate professionals in our field. If you're tuning in from across the country, this podcast is your backstage pass to the ideas, conversations, and the energy that makes the CLU experience unforgettable. We've got a fantastic discussion ahead, so let's dive into the spirit of the NLA Fall CLU. I'm lucky today to be with a good friend, Dr. Harold Bays. Harold is a board-certified endocrinology and internal medicine specialist and a diplomat of the American Board of Obesity Medicine and a diplomat of the American Board of Clinical Lipidology. He's the medical director and president of the Louisville Metabolic and Atherosclerosis Research Clinic and associate professor at the University of Louisville School of Medicine. He's also the chief science officer of the Obesity Medicine Association, and he's the editor-in-chief of Obesity Pillars, which is the official journal of the Obesity Medicine Association. Now, I've got a huge CV here for you, Harold. Look, why don't you just tell us really what drives you? What do you do every day in your practice?
Well, lately, as you know, being past president of the NLA, I'm currently president of the Obesity Medicine Association. Right. And as you know, that takes up quite a bit of time sometimes doing the kind of logistical things. But as far as my day job is conducting clinical trials. So I'm a clinical trialist, have been for over 35 years, been a principal investigator, somewhere over 700, clinical trials. And, as with you, very much engaged in publications and presentations at scientific conferences about all this wonderful science that's been going on for 35, 40 years.
That is awesome. So, in your area of obesity experience and being president of the Obesity Medicine Association, I'm sure you treat patients with GLP-1s, and we're going to have some discussions about GLP-1s here at the Fall CLU. What I want you to help us understand is a recent article was published last month in the New England Journal of Medicine about a small molecule oral GLP-1 receptor agonist called orforglipron. And so this looks like we're getting into oral options for GLP-1s. And so I want to, ask you about this in the sense that it had a lot of patients. I mean, there's like 3,100 patients in this. They were all non-diabetic, non-dyslipidemic, just obesity. Some of them had some obesity-related factors, but it was not primarily dyslipidemia or diabetes. And over a period of over a year, they lost about 11% of their mean baseline weight. What do you think about that? I mean, is that reasonable?
Before I get to that, just a little historic context, because prior to all the obesity work that I've been doing for the past, much of it for the past 5 years, because that's really ramped up in recent years. Prior to that, I was a lipid guy,
right, and
did so many lipid trials, and it's just very interesting the analogy I see between the takeoff of obesity medications and the lipid medications. Back when I started, we were first developing the statins and such, and there were all sorts of concerns about, is they're really safe to use? How effective are they? Do they have outcomes benefits? You remember having those conversations, right?
Absolutely.
You were probably having to answer those questions.
Yeah, I had to.
There's a question as to whether or not statins increase the risk of homicide. Do you remember that?
Yeah.
It's ridiculous.
Wow.
And then, of course, there's the whole issue. Yes, they're very effective, but they cost so much. Nobody can afford them, everything. You can see where all this is going. So then there was an explosion, and this explosion in clinical trial development, it got to where it wasn't simply the lowering of the LDL cholesterol. It was all the different types of mechanisms how we got there. And it wasn't just the mechanisms how we got there, it was the how were the drugs developed with regard to absorption, right? The bile acid sequestrants, perfect
Correct.
example, right?
Yeah.
So suddenly, how drugs are absorbed and interact with the gut and those types of things became paramount in what we were always talking about. It's the same thing now with obesity medications. So sure, the advent of the GLP-1 receptor agonist, injectable. That's the way it's always been. It's always been injectable. And that's been a tremendous advance. But then there was the development of an oral GLP-1 receptor agonist. And people say, well, why are you so excited about that? Well, there are a lot of reasons to be excited about it. One, maybe we'll get into this later, oral versus injectable. Why is that important? But the other thing is, Peter, it's the science. The semaglutide, the first oral GLP-1 receptor agonist, it's a peptide. You're not supposed to be able to swallow a peptide and expect to have an absorption and give therapeutic benefits, right? I mean, you can swallow peptides in a burger, but that's going to get digested, right? That isn't going to afford you any kind of therapeutic benefit. But we figured out how it is that we can swallow a pill that's a peptide by oddly enough, the methodology by which that gets absorbed in the stomach is through a technology called SNAC, S-N-A-C, okay? So that's just a phenomenal breakthrough in science. How do you swallow a peptide and have it consistently absorbed? So I was just amazing. And then somebody said, well, okay, you have an oral peptide that now you're able to swallow and it gets absorbed and it's effective. And so that's great. But what if we could develop a non-peptide small molecule? Okay, now, is that possible? Can we do that? Well, you just cited that we absolutely can. And so that kind of reverts back. Well, why? Why would you want to do a small molecule, non-peptide obesity medication? What's the point of that? Where do you see that going? Well, first of all, you can swallow it because it's not a peptide.
Right.
Okay? But the other thing is, historically, small molecules are less expensive and easier to make with greater access than the larger molecules that are peptides. And if you think about it, the idea that you could put something in a pill, that means you don't have to make the pen. And I can tell you, you probably have the same experience in clinical trials. We spend as much time evaluating the efficacy and the safety of the pen as we do the drug itself, sometimes more.
Right.
The patients have to fill out all these questionnaires, and we have to do all these PK things. And so one can only imagine that if you didn't have to invest that much in the delivery with the pen, and then you could just focus on the pill, and it could be swallowed, and it's a small molecule, and it's not a peptide. Well, now suddenly the whole issues that were the biggest deal ever just a few years ago, which is access and cost, what one would hope is that access is going to be pretty easy. It's going to, because, making a small molecule pill, maybe not that hard, and you don't even have to worry about the pen. So I know everybody wants to focus on, it's injectable, and people don't like to take injections, and it's a pill, and people like pills and everything. Peter, I'm sure you tell me. As an endocrinologist, I've been giving people injections for over 35 years. Not been a problem, right? Whether it be insulin or the GLP-1 receptor. Currently, the GLP-1 receptor agonists have just gone crazy as far as the number of people wanting these things. Injectable hasn't been a problem.
Right.
So I will ask you, do you think in your clinical practice and your research experience, I mean, is the biggest issue between pills and injectable is the fact that there's a needle?
Well, no, not in the way they've been able to deliver these injectables. I mean, the patients don't even feel a thing when
Exactly.
when they do it. So there's no, fear. You don't even see the needle at all. So that's a fear people have. So it isn't a problem with once a week. We found that with the monoclonal antibodies we do for lipid treatment, that you can actually get them if they can remember to do it once a week on time. But the injection's not the problem.
Well, for some, in fairness, there are some with extreme needle phobia.
Yeah.
So we're gonna, but I'm talking about overall, the vast majority of cases, it's not about the needle.
It's not about the needle.
Not about the needle.
It isn't. And in this study with orforglipron, they did it in dyslipidemic patients, and they had modest changes in triglycerides, 14%, very small reduction in non-HDL cholesterol. So they really weren't looking for changes in metabolic parameters much. They were just looking for the weight loss. And as I said, about 11% average weight loss, and about 40% managed to get more than 15% weight loss, which is reasonable, and for some patients that can cause important cardiometabolic benefit. I think it was interesting that in the same journal article there was the study of semaglutide 25 milligrams in non-diabetic obese patients, also without dyslipidemia, and it showed a little slightly higher weight loss, average 13% instead of 11 compared to orforglipron. I mean, in general, do you want more percent weight loss in most of your patients if they have metabolic benefits? I mean, this 11 to 13% with the orals, you're getting 15 to 18, close to 20% with the injectables. Would that drive your decision on what you would order for a patient to achieve appreciable weight loss and improvements in cardiometabolic health?
Yes, I think when we consider which of these agents might be best for an individual patient, a lot of things to think about. Number one, there is such a wide variance in responsiveness to these drugs, okay? Wide variance. All right, so that's number one. You don't know exactly what's going to happen in an individual patient, okay? That's number one. Number two is, to what degree of weight reduction are you really trying to achieve? Well, greater than 5%, you're going to get improvement in lipids and blood pressure and a lot of stuff, okay? Once you start getting greater than 10% or 15% or certainly 20%, now what you're talking about are improvements in health outcomes, demonstrable improvements in health outcomes, at least during the time periods for which we're doing these trials. So, with the semaglutide, a 15% weight reduction, you're getting a 20% reduction in cardiovascular events, right? So it isn't, this is what I always try to get across to people. It's not just the weight of the patient, it's the health of the patient. And I think we've always said that and always meant that, but until just recently, we've not been able to prove that, right. At least for the duration for which we've done clinical trials. I think all of us recognize, as with lipids, as with blood pressure, as with most anything, if you have a lifetime improvement, whatever the word improvement means, but a lifetime improvement in a cardiovascular disease metric, if you carry that over a lifetime, you could get major improvements. Mm-hmm. But you do it in a 2 to 5 5-year clinical trial, sometimes that's tough to show, right? Tough to show. So I think even just a 5% weight reduction in a patient with overweight and obesity, particularly if they have evidence of metabolic dysfunction, I've called that adiposopathy, or the sick fat, okay?
Your term.
Yeah. Then yes, in a lifetime, yes, you're going to get substantial, I think, improvement. But with regard to what we can prove, that's when you start needing that 10 to 15% because of the duration of the clinical trials. And now, like I said, we got drugs out there now that are getting 20, 25% weight reduction, approximating what you might see with the bariatric surgery.
Right.
Now, to get to your, because I know this is the National Lipid Association, I would just point out, brought this trusty dusty article with me. You may recall that we published this article, Obesity, Dyslipidemia, and Cardiovascular Disease, a joint expert review from the Obesity Medicine Association and the National NLA. And this thing is a beast.
It is.
It's a beast. We went just from the very, the basic science and how it applies clinically and such. And what I really appreciated most about this effort is so much of the very basic science that we got came from the guys that we came up with. Yeah. Scott Grundy and all these icons and everything. What was surprising to me is this data that had been generated that was so critical to the foundations of what we wrote came from the 70s, and as far as I could tell, have never been repeated.
Really?
Yes. I tried to look for a lot of these things to say, I would like to get confirmation, but I guess if Scott Grundy does it,
everybody believes it.
You don't have to confirm it.
Yeah.
And there was other ones too that, again, people, the icons of the day that did this basic research and such. So I guess the takeaway message for those people who haven't read this, and I'm going to encourage people to read it because I think it's just so full of things that I think are foundational to clinical lipidology. But to your point, when you do get substantial weight reduction, you're going to see substantial improvements in blood sugar, particularly in people with diabetes.
Right.
Take it to the bank. Systolic blood pressure is going to get better. Okay. So there you go. Blood pressure. Okay. But what about lipids? Well, as it turns out, unless you start getting 15, 20, 30% weight reduction in a person with the obesity or the overweight, and until you get to those numbers, the typical effect is maybe a 1 to 5% reduction in LDL cholesterol, maybe a 5% increase in HDL cholesterol, depending on when you measure it.
Right.
If it's during active weight loss,
it goes down.
It goes down, particularly if you're on a complex carbohydrate diet, right? So HDL cholesterol can go down transiently. But triglycerides will go down 10 to 15%. So that's what you typically see.
Right.
And that's what you're going to see with the liraglutide, the older GLP-1 receptor agonist. That's what you're going to see in many of these oral GLP-1 receptor agonists. You're going to see that modest improvement. And so what does that mean to a clinical lipidologist? What does it mean? What it means is when you have a person with overweight or a person with the obesity, and they're embarking on an effort to try to get that under control, okay, getting to have that obesity and overweight managed, yes, it's fabulous you're bringing down that body weight, but knowing that it's often very challenging to get the LDL cholesterol down,
right,
you almost have to take a dual approach and treat the lipids independently.
Right.
Now, we like to treat the patient as a whole. I believe that. You
Right.
treat the whole patient, not just pieces of patients. But unless you're going to be doing bariatric surgery, or unless you're going to be using some of the, the investigational agents, medicinal products that are in development, I don't see how you step away from statin therapy, for example.
I agree.
It's got to be a dual, so everybody's all excited about the weight reduction, and they should be.
They should.
But that doesn't mean you shouldn't be aggressively managing the lipids, and I think that has to be done concurrently. I
absolutely agree with that. Do you see, the long-term management of obesity is another issue here. You get, if you take the GLP-1 injectables, everybody loses weight, then you get randomized to take it or continue it or not continue it. The people who come off of it tend to regain some of their weight, and those who stay on it continue to maintain their weight loss. Injectables, is that a viable 10-year, 15-year plan for these high-risk patients who need to keep their weight off? Or do things like these oral GLP-1 receptor agonists become a more viable long-term strategy for weight management? What do you think?
Well, I think two things. One is obesity is a disease.
Right.
Okay? Diabetes is a disease. Hypertension is a disease. Dyslipidemia is a disease. And I think the first thing, there needs to be a conceptual realization that it is a disease, in the sense that if you had a person with diabetes that's on diabetes medications, or they have hypertension and they're on blood pressure medications, or if they had lipids and they're on lipid medications, nobody would ever go to any of those patients and say, well, here's what we're going to do. We're going to give you medications to treat your diabetes, hypertension, dyslipidemia. And once we get you to where we think these medications have really got you controlled, we're going to stop them.
Yeah.
Okay. And just see how you do in maintenance.
Right.
Nobody would ever do that,
No.
would they? No. And then, and nobody would be shocked to say, oh, well, it's so very odd that, that you had the diabetes and the hypertension and dyslipidemia. We treated you for medications for each of the three. And then when you stopped them, all your parameters got worse.
Right.
That's so unexpected. No, you would never say that. It's the same thing with the obesity. It should be the expectation that, yes, people are going to require lifelong treatment. Now, are there individuals that either with medications or not with medications can turn it around on their own? Yes, it's like 5%,
Yeah.
right? I would say, though, is it possible that there are many patients out there with type 2 diabetes mellitus, if they really engaged in aggressive physical activity, nutrition, those types of things, maybe there's 5 to 10% of them that could stop their diabetes medicines, right? Maybe hypertriglyceridemia in some individuals,
Correct.
right? Maybe not so much LDL cholesterol, but
Right.
certainly triglycerides. You see what I'm saying?
Correct.
Blood pressure. Is it possible that there's patients that if they aggressively engage in nutrition, physical activity, behavior modifications, that they could come off their blood pressure medications? Yes, we've all seen them.
Mhm.
We've had patients like that. But again, nobody has that as an expectation for diabetes, hypertension, dyslipidemia. And I think that's the way we need to look at obesity. Okay. Your second part is, what about maintenance? Well, you could just keep taking what works.
Right.
Okay, you could do that. But if there's reasons why it is that you say, well, I would like to maybe transition from an injectable over to the pills, is that a viable option? And the answer to that is we should know pretty soon, because that's what the clinical trials are
Trying to
you're,
do.
you're not the first one to come up with
Yeah.
that. Okay. I don't want to burst your bubble here, but I mean, there's a lot of people that are kind of thinking in that way. The only question in my mind is, at that point is, well, why would you do that? Why wouldn't you just continue the injection if it works?
True.
And it would revert back to what I said before, is if you were to say, well, yes, but the non-peptide oral formulations are more easily accessible, and they're less expensive, and maybe there are things that people can actually take long term.
Right.
And if you could demonstrate a persistence of weight reduction by use of these agents after the injectable, well, how great is that?
It is.
Right?
It would be,
How great
it
is
would be a
that?
great option.
It'd be a great option.
A
That's
fantastic
right.
option.
Yeah.
I appreciate you giving me all your feedback on this. One other thing while I have you here, you are going to be also presenting in a session with Dr. Eckel, but your specific lecture is on the role and influence of bariatric surgery.
Yeah.
So I want to ask you,
Yeah.
when and how does bariatric surgery become part of the conversation for weight management in which patients?
Well, optimally, it would be, part of the conversation in a patient that says, okay, I've already engaged in healthful nutrition to the best of my ability, and I'm engaged in routine physical activity to the best of my ability. I've undergone behavior modification. I've been evaluated by a team through a team approach and whatever. But I still have not just the obesity, but serious complications of the obesity. What I would say is, in a true patient-centered approach, the option of bariatric surgery should be part of the initial discussion, right? There needs to be a discussion of all available options. Now, I think most clinicians and many patients are of the mind, well, particularly if you're talking about certain types of bariatric surgery, maybe the pills, or maybe the oral formulation, maybe that ought to be an initial consideration, but I don't think it should just be taken off the table just because, right, you haven't tried the pills yet. Okay. All right. So let's say you do try the oral formulations and it's not getting it done. Well, then, yeah, I mean, I think bariatric surgery it's been around a while,
Right.
Proven safe. And not only has it been proven safe, but Peter, my goodness, the only drug in my lifetime, let me see if that's true. Okay, I think right now, maybe I'll think later and I'll think what I'm saying is ridiculous. But I can only think of one, if we're talking about in the metabolic space, one medication that even approximates the cardiovascular disease benefits of bariatric surgery, and that would be the SGLT2 inhibitors.
Oh, yeah.
Right? At least for one trial, the IMPA-REG study, right? I mean, our statin trials didn't show that. They showed robust benefit, but not in the magnitude that we see with the bariatric surgery. So, and even with the semaglutide, I mean, 20% relative risk reduction is great, but it's not 50%.
Correct.
Right? And then you got the mortality data that's favorable and such. So, bariatric surgery has profound benefits documented through well-conducted clinical trials. So if you're an evidence-based medicine person, you need to think it needs to be an option.
Needs to be an option. Do you get put that option a little bit higher up on your discussion list if a person's baseline obesity is more than 40%?
Right. If they've tried the other things, they've had the team
45
approach.
or something like
That's
this.
right. That's exactly
Should
right.
probably be talking more bariatric surgery up front than the other
For
options.
many patients, I think that's exactly right. I mean, again, what is the objective? The objective is to improve the lives of our patients through evidence-based science. And the science is there.
It is.
And it isn't just the science between, and again, I'm not a bariatrician. You don't want me doing surgery because I'm not a surgeon, and I don't have a bariatric surgery practice. I'm just telling you what the science shows.
Right.
And if our objective is to improve the lives of our patients through evidence-based therapy supported by the science, I don't see how you ignore bariatric surgery.
I agree. I tend to agree. And again, the long term, there's persistence after bariatric surgery. So that's the other part. The more the person needs it, the bariatric surgery will get their weight down. But then you're talking about being able to maintain that over a long period of time. Obviously, the cumulative cardiovascular and metabolic benefits of that are just amazing. Do you, if you do recommend bariatric surgery, is the laparoscopic Roux-en-Y, is that the best, or what do you think are the? Yeah,
I mean, I think the two that people talk most about are the gastric bypass and the sleeve gastrectomy.
Okay.
So those are the two, and it depends on like which institution. I mean, I'm just throwing this out there. I'm just telling you, there's still places out there that do lap bands.
Oh, yeah.
Okay. They're still, and I just, look, if somebody's out there that does lap bands, I'm not being disparaging everything, but I just think the consensus is, I think there's a general consensus that if you're looking at health benefits, that there is just not a comparison between the old timey, lap banding and such, and the potential health benefits of sleeve gastrectomy and then the well, let me ask you. I mean, your institution are how many people are doing lap banding right now?
None.
Oh, none.
None. They've sort of given it up. There are too many complications with it, which you end up having to go back in and redo the surgery and all that. Which once you're done, one and done, if you end up doing gastric bypass surgery, it's done, and there's no problem, and the outcomes are even better than extra gastric banding. So most of them just go with the evidence and move forward with the best approach and so forth. So, yeah, I mean, I think that if you're into helping patients with weight loss, what's wonderful is we've got a lot of options now.
We do now. But just think about it. It wasn't that long ago.
I know we didn't, and
we didn't have the options.
And it's wonderful. And I think that we're bringing the concept of obesity into the NLA now because of the benefits that are available, and because of the cardiovascular benefits and cardiometabolic benefits that weight loss achieves, and even with these GLP-1s, where the outcomes have been
So I want to go back to this analogy thing that we talked at the very beginning. Remember I said, that the analogies are striking from when I first started. Okay. So when I first started in clinical research, we were developing the statins. Okay. And prior to the statins, the only thing that we had to treat people for their lipids were fire and sand.
I know.
Right?
Bile acid resins and niacin.
Bile acid sequestrants and niacin. What a horrible thing to do to patients, right?
They hated it.
Yeah. The fire with the niacin and the sand with the bile acid sequestrants. We were developing some of the more advanced, if you can call them advanced, bile acid sequestrants. And we were comparing taste tests to the things. So there was the cholestyramine, the brand name, and then there was the cholecylamine.
Right.
But then we had this generic cholestyramine.
Right.
And my staff, back then you could do that kind of stuff. The staff tried like all three, and when they tried they didn't like them, but when they tried the generic cholestyramine, they threw up.
Yeah.
Because it was just brutal.
Yeah.
And what I would say is, up until just like 5 years ago, we just didn't have that many. We had some options, and some were very good, but nothing like what we have now, and nothing like what's coming.
Coming for the obesity management.
And for the lipids, we went from fire and sand to statins, and then we had ezetimibe,
right.
And then you throw in bempedoic acid. And what about the
PCSK9 inhibitor?
And then that changed everything.
It is, and it's improved our ability to take high-risk patients and give them a long-term strategy in reducing cardiovascular risk. And I'm just excited about the obesity part, and that we're trying to incorporate that into the whole concept of cardiometabolic health in our patients, because lipids are part of that. But now obesity is something we've got on our hands, and I really appreciate you coming to the NLA, and I know you're a little bit more involved with the Obesity Medicine Association than the NLA, but I really appreciate you being here, Harold.
I appreciate it.
And sharing your expertise and commenting about some of the more recent research that's come out, because this is awesome. And I really hope our audience has gotten something out of this and fires them up a little bit about wanting to take on obesity management in their practice. I think that's fantastic. So again, I appreciate you being here. Thank you so much for the interview.
All right. Thank you.